We have about 10 or 12 minutes for questions, comments, thoughts. Please.
Hi, Julie Fritz, the University of Utah. So I have kind of two questions, but I think they intersect. I didn't hear you talk about other kinds of value-based payment reforms that might be at play here in terms of shared savings or bundling or some other kinds of innovation that perhaps have a role in chronic pain. And perhaps some of those solutions might also address another barrier that wasn't talked a lot about, but I hear from my clinical colleagues, which is some of the reimbursement rates from payers to the provider for various services that we're talking about being low enough to be a concern on the provider side, and particularly in thinking about health systems and where money can be made in terms of pain and interventional procedures. So.
Who'd like to take a first crack at that?
Well, I'm happy to dive in
on that.
Yeah. And we're probably, given we have 110,000 providers in our network, we hear this fairly often.
I suspect.
There's two answers to it. Number one, we have 500 requests to join the network a month. Nobody leaves. And so the rates have sort of settled out where the market is on a pure sort of supply-demand basis. That's one answer. The other answer is when you look at the rates that are paid and the value that's created, we think the rates probably aren't where they should be. And so I didn't mention it in the overview, but the actions we are taking is those non-pharma therapies that are working with us in this model of the future. One bullet item was we are increasing level of reimbursement to these providers. So it is on the table. We are looking at it. Our belief is, in-network outpatient practices are important. We need to keep viable, and unit cost is a part of it. To your first question on bundled payment, the challenge in surgery is easy, right? You put a little time period on the front end, time period on the back end, bundle it up, pay it, and put a warranty on it. Multiple visits over weeks to months become really challenging in terms of bundled payment that might involve multiple providers and subcontracting out. And we actually have patent protection on a value-based bundled payment model that you think waiving copays and deductibles for a couple visits is hard. Doing a bundled payment model in the claim system of today with all the accumulators and subcontracting out, it is really tough. So I agree, it's really attractive, on a PowerPoint presentation, but when you get into the plumbing, wow, is that complicated. So it's not that we're not working on it, but complex.
Great. Dr. Ling?
Yeah, and I completely agree about how difficult it is with all of the complexities. Operationally, we also have in the Innovation Center have developed several bundled payment care initiative models, and do wonder whether there might be an opportunity or because it's so hard to know when you start, when you end, and what goes in the middle. The surgical was fairly straightforward. Oncology care, starting with the first infusion of chemotherapy, one could argue that should have started earlier, but operationally. Welcome some thought and conversation about how would we define an episode, right? And I think there may be a million different variants of an episode. So I'm not sure if science will lead the way or just the practicalities. I will also say that there are other alternative payment models, advanced alternative payment models that would be worth taking a look at. We really have not had a pain-specific model, but if the thinking that people who have chronic pain require more time with their clinicians, coordinated care services, perhaps that would be paid in a different way rather than on the clock, that we one place to look would be the comprehensive primary care plus alternative payment model, specifically Track 2, where there's a base payment made to the practices to acknowledge that something else is needed. But in that construct, in that population, we also have other difficult to manage diseases, right, such as dementia, such as mental health, mental illness, depression, all of those. So I think if we actually look at that and see what might of this might work, I think that will be a step forward.
Thank you. Dr. Connector.
First, I want to say very impressed, especially with David, to be a payer in a room of integrated providers. That's very brave to get a gold star. Yeah. With that said, I have a question. With that said, I have a tough question for you. Because of the lack of coverage, as a provider, we get a lot of denial letters that say certain therapies like biofeedback for back pain is experimental or investigational or whatever language might be, which obviously are outdated. With that said, other than an appeal letter, which all of us have tried and there's kind of appeal fatigue, what would you suggest to providers as a group that would be conducive and not caustic, to increase our burnout, that would actually help move those published statements to be closer and less discordant with guidelines?
Well, I think we're in the moment right now, when we have the epidemic we're dealing with, that has forced a lot of innovation and a lot of rethinking of sort of legacy policies. It's given us a sort of an opening to really take a look at coverage, and for an issue like biofeedback, I think I've got your contact information. It's all of us together make this thing work better, and so we all have a role to play. And I think so. To coverage policy, I mean, it's a long, sort of rigorous, and CMS is no different, right? If we want to introduce a new therapy, what's all the science behind it? How are we going to cover it? What are the CPT? How are we going to pay for it? How much? So it's a long journey, but we're definitely happy to take that journey, and we do have a process to evaluate new therapies to introduce into coverage, and I'd love to explore that one with you. So the timing is great, though, because we need to do something different than we have in the past, and there's therapies out there that are helpful.
Dr. Alexander?
Yeah. I mean, I think I heard your question more about coverage policies rather than the letters per se. And what I can say, we interviewed 45 senior executives from plans, and invariably there's a lot going on within the plans. So I really would come back to this notion that this is hot, that payers are struggling with this, and that they're under the microscope, as they should be. And payers can either be part of the problem or part of the solution. And so, but payers, like other stakeholders, develop policies that serve their organizational and fiduciary needs. And so I think that part of the challenge for this group is to identify recommendations and policies and guidelines that are consistent and sort of not naive and are cognizant of the fact that payers are, in the case of commercial payers, money-making organizations.
Question over here.
Yeah, I just wanted to, in Lynn
Your
DeVar,
name and-
Seattle, Kaiser, perseverate for a minute on Julie's question about bundled payments, and perhaps for Sherry's going a little bit with alternative payer models. And I thought, Kat, you might speak up about this, but I know it's a lot to unpackage. Kat's working with us on a PCORI-funded evaluation of the Oregon initiative. And one of the things that's it's complex but exciting about it is that Oregon has coordinated care organizations. There are 15 of them in the state. They all have some latitude about how they organize services. And so we feel like there are a lot of, sort of mini natural experiments going on that we can use our mixed methods to really drill down and say, what were the flexible ways in which they were able to use these things that might maybe resulted in better patient outcomes. Some of those things are hard to measure because they can do, innovative things within their clinics where they don't charge for things in ways we see in claims and so forth. But I think there are these complementary efforts that we can make besides clinical trials to really look at some of these natural experiments in the way that care is organized and learn a lot from it. So I just wanted to add that.
Thank you. Any comments about that? Let's give Dr. Livingston
Yeah,
a chance.
thanks for bringing all of that up. There are a lot of natural experiments going on. The whole thing is a natural experiment. I think that was the name of our grant. But because of these 15 different CCOs, one, for example, has done this very intensive model where, for 20 hours a week, you do intensive pain education for weeks and, for a 4 to 6 week process. And so they're testing that and seeing if that's effective. Others, kind of widely open acupuncture and then restricted it because they didn't find that it was improving the outcomes of their population and had huge costs. So we're seeing a large number of experiments that are actively unfolding, and they have this flexibility to do their own payments and kind of through a PDSA cycle, as it were, come to a better option. They aren't formalized, such as through CMMI, but I think that we can learn a lot through these.
And this is Sherry. I would agree that we can learn a tremendous amount. And, if we can consider these like pilot models or, from a national perspective, I think there's a tremendous amount to learn about the who, the what, the how, and also actually what you've done, which is like completely flipped the model, right? Which is in and of itself a natural experiment. So we're really looking forward to learning from this.
Thank you. Dr. DeLito.
Tony DeLito, University of Pittsburgh. I'm going to go back to the bundling issue, and I fully appreciate the fact that it's complicated and everything else, but you shouldn't really look past the effect that had. When CMS came out with the total joint bundle and then they said our area had to do it, the first thing our system did was say we can't do it. And when you came back and said you have to do it, it didn't take 17 years to implement evidence in practice. It took 17 weeks. Honestly, with 8 different acute care hospitals that even though we're an integrated system, we were not talking to one another. We had, it was profound, that change that caused. And we're better. We're better for it. The hospital system is much better for it. We had variations in care ranging from aspirin for prevention of deep vein thrombosis, all the way up to Lovinex being done prophylactically. It was just incredible how that effect that had. So you shouldn't lose that in the process. That was if for no other reason, it was very effective in causing a evidence-based change.
Great, thank you. So let's thank our panel. Wonderful presentations.